Hello, everybody. Welcome to the Royal Statistical Society's Official Statistics Section's joint meeting with the Health Statistics User Group. And I'm here to welcome you to the virtual Royal Statistical Society and hand over. I'm chair of the Official Statistics Section, and I'm going to hand over to Dina Ledbetter, who's chair of the Health Statistics User Group, who is going to chair the webinar. Hope you have an enjoyable morning.
Great. Thank you, Alison. Can we just have the next slide, please, Luz? Okay, so so people should know that this is relatively short webinar with quite a lot of speakers running from 12 until 1:30. And as we've said, we are recording this so that it is available for people who haven't been able to make it today. And so welcoming on behalf of the Health Statistics User Group, we are running this jointly with the RSS Official Stats Section. Next slide, please. So just a bit of housekeeping. You will see that everybody is muted, apart from the speakers. And I just put a note in the chat to say, any questions, comments, put them in the chat, but write question at the start and the speaker, so we know that we pick them up at the end. We make sure we are actually picking up all the questions. Recording of this session will be available for 2 weeks afterwards, because things change so quickly. We want to make sure that we're not holding an out-of-date recording on the website. So that will be available. The presentations will be available immediately, so there's no need for you to write any notes from the presentations. There will also be a report which will follow in a week or so's time, which will include the Q&A and any additional comments the speakers want to make to the questions. Next slide, please. So the speakers, we have Sarah from Office of Stats Regulation, who will do an introduction, then Jennifer from DHSC, and then we have speakers from Public Health Scotland, from the Welsh Government and Office for National Statistics. And as those of you who were listening earlier will know, Sian is not able to join us, so it'll be just Alexandra from the Welsh Government. We will just run through all the speakers one after the other without any break in between, apart from just, introducing the next one. And then we will go on to the Q&A. And in the Q&A, we will pick up on the questions and we will summarize those for the speakers to give an immediate response. So that's really all that needs to be said in terms of the brief introduction. And I will now hand over to Sarah to give some scene setting on behalf of the Office of Stats Regulation. Sarah.
Thank you. Okay, can we go on? I've got a sort of first headline slide, so if we can skip forward straight to the next slide. My introduction is very short, so I'll just start off. I'll give a very brief introduction to OSR, just for those of you who aren't aware who we are. And effectively, we are the regulatory arm of the UK Statistics Authority. And what that means in practice is that we have a statutory role to promote and safeguard the production and publication of official statistics. And in practice, this means that we provide independent regulation of all the official statistics that are produced in the UK. So the sorts of things we do are assessments of sets of statistics to determine whether they can have the national statistics status. And we deal with a lot of inquiries, generally across all topics, across statistics, if people are concerned, if there are issues to do with the quality or transparency and so on. We do lots of other stuff besides, but those are perhaps the sort of main activities that are relevant here. It's very important to be clear, we don't produce any statistics ourselves, and we are separate from the Office for National Statistics. So we are independent and we work across all government organisations, not just the ONS. Can we go on to the next slide, please? So I've just got a couple of slides. One is perhaps a more formal thing. Obviously, we've been in a very sort of strange time for coming up for nearly 12 months now. And the pandemic has thrown up numerous challenges for producers. Many of them have had to develop new data collections sort of very quickly. They've had to take decisions over which existing statistics they might pause or change, or they might suspend the national statistics status because they've perhaps had to have a slight drop in quality. And we're going to see some good examples of the work that the statisticians have been doing in response to the pandemic. But even now, almost a year in, we can see how things are still changing very quickly. So producers are having to develop vaccination statistics and work on these sort of as they go. Things like test and trace, this is still developing, week on week and as time goes on. So it's been a really sort of challenging time for producers. At the start of the pandemic, we produced various pieces of guidance which we hoped would assist producers throughout the pandemic. And these covered both the development of new statistics and changes to existing statistics. So hopefully they were there to sort of help producers with any difficulties they were facing. I won't run through them all. I've put the links on there. They are all active links. So if anybody's interested in those, you can go and have a look at those after the presentation. So just one more thing. The next slide, please. So this is a bit more sort of informal. Obviously, it's been new territory for us as well as producers. We were sort of thrown in at the deep end with dealing with the new data and sort of queries around that. So we've learned a lot as we've gone along as well. So as well as the formal guidance that we've published, I've just pulled together some informal pointers that I hope will be helpful for those of you who are producing statistics. The main things really are trustworthiness. Obviously, at any time, but even particularly now, statisticians shouldn't be misleading the public, should be very transparent about your plans and your changes for your statistics. Be clear what they do and don't say, what their limitations are. We're trying to encourage producers to publish as a default. Whatever you've got, try and get it out there in the public domain so that people can see the data and try and understand it. And obviously trying to provide as much sort of context, insight and granularity as can be managed. Timescales are very, very tight at the moment, but if you can just provide as much insight as you can, then that's helpful. In terms of collaborating and sharing knowledge, it works on all levels, really. We've seen statisticians and analysts across the 4 nations working really well together to ensure that information is available at the UK level, as well as for individual countries. This has been hugely impressive, highly commendable. But it's also important just to share your knowledge more informally. So that's happening between analysts, but also things like this webinar today, presenting and discussing your work with your colleagues and just sharing whatever knowledge you can, really. So that's it from me. I shall shut up and hand over to Jennifer.
Yeah. Thank you, Sarah. Now we move on to Jennifer Snape, who's going to be talking about the NHS Test and Trace statistics for England. Jennifer.
Great, thank you. All right, hi everyone. My name's Jenny. So I'm the lead statistician for the NHS Test and Trace Statistics, which covers England. And today I'm going to give you a bit of an overview about how we developed the publication at pace. So just quickly before we get started, for people who don't know much about it, the publication is a weekly publication and it comes out every Thursday at 11 a.m. And as part of that, there is a statistical commentary. We have supporting data tables, which are in spreadsheets, and we also have a detailed methodology, which explains a bit about where the data's come from. So if we just move on to the next slide. Cool. So today I'm going to take a bit of a trip down memory lane and talk you through sort of our development timeline and some of the milestones in how we developed the publication. So the reporting team sort of started at the beginning of May. I actually joined a month later, so I started at the beginning of June, just after the launch of the NHS Test and Trace programme, which was on the 28th of May. And we published our first statistical release on the 11th of June. So this covered the first week of the programme. It was very high level. It contained just tracing data. And it was about 10 pages in length, so it was quite brief. Generally, our strategy for the publication was to start simple and then build over time. So it was this kind of iterative approach, which worked quite well for us because it meant that we were able to be flexible and sort of change what we were working on depending on what the priorities were at the time. And the priorities did change quite frequently. Ultimately, we just wanted to get data out as quickly as possible. So users had access to it, and for transparency reasons. So we tried to sort of get headline figures out as quickly as possible and then break that down further in subsequent weeks when we had more time. So the next thing that we did was publish our statement of compliance with the Code of Practice of Statistics. And this was really important to us because obviously these are high profile statistics and we wanted to sort of from the start set out our intentions in terms of trustworthiness, quality and value of the statistics. The next thing we started working on was the addition of testing data. So up to this point, we'd just been publishing things about tracing, but adding testing data sort of completed the whole process of test and trace. And at the end of July, we had our rapid review from the UK Stats Authority. So we got back quite a lot of kind of feedback and things to improve for our publication, but we also got quite a lot of positive feedback as well. And I've been told it's quite rare to get so much positive feedback. So this was very much a sort of highlight for us in terms of the development of the publication. So we did want to work on the sort of constructive feedback we got. So over the next couple of weeks, we worked to restructure the publication. We sort of changed the narrative to make it more clear and sort of improve the commentary and also the graphs that went alongside it. And it took us a couple of weeks to do this because at the time we were a very small team. There was only about 3 of us who were putting together the publication every week. And if you can imagine you're doing a weekly publication, there's not a lot of time left over at the end of the week to sort of do development. So it did take us a bit of time. But what we published at the end of August, we were quite happy with, and actually that's the same structure that we still have now, so it sort of stood the test of time. So moving on into the autumn, we actually got more resource for our reporting team, which was amazing, and our team has sort of been growing ever since. So we started focusing a lot more on new developments, and we put out a lot of new breakdowns. So we added things on regional data, we added new demographic data for people tested, and we also added some new test level metrics, which we're looking at number of tests for different types of tests as well. So if you can sort of imagine from June to November, we'd been just adding so much data. The publication had grown massively in length. So it was 10 pages at the start of June, but by November it was around 40 to 50 pages, which was great for users in terms of getting more detail and access to more data. But it also meant the publication had grown very long and there was now a problem of duplication. So a lot of statistics have been published in our publication as a way to get data into the public domain quickly. But since then, they'd then been added to the COVID-19 dashboard and other publications like that, which is sort of the main place people get their statistics from. So we ended up in a situation of things were being published in multiple places, which wasn't always that clear. So from December, we've sort of started a new project of work around consolidation. So we've been looking at these areas where we've got duplicate statistics and we've been working to cut them down and make things more clear. And that's pretty much where we still are in January as well. Hopefully next week, we're going to be launching a user survey, which will be available on our main collection page. And I would love it if everyone listening to this presentation could answer our user survey. We're asking questions around who's using our data, what you're using it for, and what you'd like to see in the future. And we are going to be using the results from that survey to influence sort of a secondary structure of the publication. So we'll be developing that in February, hopefully for the subsequent months. So if we move on to the next slide. Just quickly in the last couple of minutes, I also wanted to cover a bit about the challenges that we faced developing this publication. So you can see some of those on the slide. I've already mentioned the sort of weekly development cycle, which was a challenge for us, particularly at the start of the process when we were quite a small team and we sort of had to balance just getting the statistics out with doing developments. The other one that I'll just mention is the evolving program. So since the start of the test and trace program, things have changed a lot. I'm sure you're aware of how different types of tests have been introduced, different ways of getting a test, different ways of contact tracing, which has meant we're sort of constantly having to keep up with these changes. Anything that affects how the data is recorded affects how we have to sort of explain it. So there's never been a point where the publication has been finished and we can just relax. We've always got to be keeping up to date with these changes. So that makes it quite exciting, but also it's a new way of working for us, so we've had to adapt to that. And then just finally, I've got one more slide. So this just gives you a flavour about what we're going to be working on going forward. So I mentioned the user survey and our publication development. But also we're still working on some new breakdowns to add more value. So at the moment, we're looking at mass testing, so sort of rapid testing in different groups. And we're also looking to add some more information around contact tracing as well. So I think that's all the time that I have, but thanks everyone for listening, and I hope that was interesting. Yeah, happy to answer questions, or you can drop me an email if there's anything else that you want to know. And I think I'll hand back at this point.
Great, thanks very much. Thanks very much, Jenny. So as I say, questions in the chat box, please. Can we now then hand on to the next speakers, which are speakers from Public Health Scotland. Scott, Emma and Jade will be doing a three-hander here. So over to you, Scott, to lead off, is it?
Yeah, thanks very much, Dina, and great to be here, everybody, and hello from Edinburgh, where we still have snow. So it's, I have to say, one of the advantages, if you can call it that, about COVID is that the ability to have sessions like this and have people joining in from all across the country, which is great to see. So yeah, there's going to be three of us who are going to talk about what we've been doing in Scotland. I'm going to do a bit of an introduction. I'm the head of statistics in a body called Public Health Scotland, which I'll explain about in a second. And then my colleagues, Emma and Jade, will talk you through some of the outputs to give you a bit of a flavour of the types of stuff that we do in Scotland. So if we can go on to the next slide, please. Okay, so just to kind of set the context for what's happening in Scotland, just a reminder to everybody that health is a devolved matter. So the response to COVID and how we're dealing with it is a responsibility of the Scottish Government, who work with a range of bodies, both nationally and locally. And the body that Emma, Jade and I work for is a body called Public Health Scotland, which was actually only created in April 2020. Partly to try and address public health in Scotland, but obviously COVID has played a major part in the early year of the organisation. I don't think we knew when we created Public Health Scotland quite what we'd face in our first year. And part of Public Health Scotland's role is to lead many aspects of Scotland's COVID response. So some of you may be familiar with the kind of old terminology in Scotland. So you may be familiar with the Information Services Division, or ISD, and Health Protection Scotland. So ISD was the main stats body for NHS Scotland, and Health Protection Scotland was the main, as it says, health protection body. And these are both now part of Public Health Scotland. So essentially the majority of public-facing stats about COVID in Scotland are produced by Public Health Scotland. And we do a range of stats that are produced daily, weekly, and ad hoc. And what I'm going to do is just talk you through a couple of these and then hand over to Emma and Jade, who will go into a bit more detail. So if we can go on to the next slide, please. Okay, so in terms of where you can find COVID statistics in Scotland, and at the end of our presentation, we've got a series of links to take you to the various websites that publish this. Just going to highlight that we publish daily statistics at 2 p.m. each day. The very high level figures go out on the Scottish Government website. That's to correspond with statements made by our First Minister and her Cabinet colleagues. And there's also a much more detailed breakdown of the same statistics, which goes on the Public Health Scotland website at the same time. And we have a COVID-19 dashboard, which has been a huge success for us. Which gives much more detailed breakdown of the figures on a daily basis at local geographies, and Emma will talk through that in a second. And we also release all of the information in open format so people can pick up the data and use it themselves, and that's been a big success, and both Emma and Jade will touch on that. We also produce a weekly COVID-19 report, very similar to the one that Jennifer highlighted. And what we do there is bring together a range of statistics showing essentially what's been happening over the course of the previous week. Some are produced every week, and others we include as one-off special topic chapters within the report. And a bit like Jenny was saying, our report has grown over the course of the pandemic. And so we are a wee bit more selective about kind of the key statistics that go in the main report. And there's an accompanying dashboard with a lot more detail of the other statistics, which Jade will touch on when we come to her bit. Also to highlight, we produce a whole range of other reports on COVID, which are available from our website. Most recently being our evaluation of shielding in Scotland, which was published yesterday. So just to kind of highlight that we've got the kind of routine stats that go out every day, the weekly synopsis in the COVID report, and then we've got a range of other reports about all sorts of aspects of COVID that we're also responsible for. But they're all published by Public Health Scotland, which hopefully makes it a bit easier for users to find them all. And just to highlight that all our non-daily reports, so the weekly report and all our special reports, are all published at 12 noon every Wednesday. Traditionally, health statistics in Scotland are published on a Tuesday at 9:30, but we got agreement from the Office for Stats Regulation to separate out the COVID reports, and they all come out at 12 noon on a Wednesday. That's partly to coincide with statements by the First Minister around about that time, and also to allow the statistics to be debated in Parliament in sessions that are usually held about COVID or First Minister's questions on a Wednesday and a Thursday. So I'm now going to hand over to Emma, who's going to talk a bit about our COVID daily dashboard, and then Emma will hand over to Jade, who will touch on the weekly report. So over to you, Emma.
Thanks, Scott. If we could go to the next slide, please. So as Scott said, I'm just briefly going to cover the daily dashboard that PHS has. This has been an evolving output over about the last 9 months, and it now includes information on positive cases, testing, COVID confirmed deaths, hospital admissions and ICU admissions. And as Scott said, it's updated at 2 p.m. each day, and there's accompanying open data. So all the data that's underlying all the visualizations in the dashboard can be downloaded and used by other people as well. There's trend data available, and it's also possible to break things down by different demographics like age, sex, and population. And trends are also available for different areas as well, so the local authorities in Scotland and NHS boards. So all of that data can be visualized, and as I say, it can be downloaded and used for other purposes if people want to. We've got local maps available, which are similar to what's available for England and Wales, I think. So there's what we've done is give a kind of local authority view, and people can then drill into each local authority. So that example there is for Glasgow City. Each of the smaller areas are intermediate zones, which are a kind of neighbourhood geography in Scotland of between 2,500 and 6,000 residents. So fairly small areas. Challenge has been that variable population at that level and coming up with an approach that is kind of robust enough and meaningful for people, but gives them the level of information they want. So that's been quite a challenging thing that we've been working on over the last few months. We are continuing to add further content, and one of the big bits that we're working on at the moment is vaccination data. So hoping next week to be able to add daily update on vaccination data to the same dashboard as well. I think, as Scott said, it's been very popular, massive usage, much higher than we've seen, understandably, given the context, and a wide range of different users. So lots of different feedback coming in, which has informed the development. And some of that's quite iterative, quite small tweaks here and there just to clarify things. Some of it's been quite big changes as well. And I think it will continue to evolve and change as we go forward. So I'm going to pass to Jade now. If we could go to the next slide, please.
Thanks, Emma. So I'll just chat through our weekly report that we publish every week on a Wednesday at 12 noon, as Scott says. We have a report and a summary that is published, as well as infographics, and the report can range from 20 pages to over 50 pages, depending on how much new information is going out that week and how much detail we want to go in to try and explain to users. We can really zoom into specific things. The infographic on the screen is an example of when Blackpool was showing as a contact risk that we were advising people not to travel to Blackpool. So we try to get that into the public domain and is user friendly, so people can understand that the links on what's going on. We then have a detailed trend and dashboard, which is produced in R Shiny, and that contains all the information that we publish every week. It's got testing numbers, it's got hospital admissions, it's got index cases and contacts, time performance analysis, and this is what we use to answer many parliamentary questions and FOIs and performance queries. We try to really take away a lot of the heat from the analysts producing information in response to queries to actually refer to the trends.
Sorry, can I just interrupt? I think we need the next slide, don't we?
No, it's still there.
It's still okay. Okay.
Yeah. We also have our open data, which can be interrogated and can be accessed via API, so that people can just go in, take the data and do what they want with it. If they want to create their own analysis, then all the information is available on that open data website. Let's go to the next slide. Our open data has had the most hits that we've ever seen for any topic, for COVID, contact tracing information, tests. It's all available on there, and it really has increased the use of our open data platform. And it's really drawn focus to other health topics that haven't got their information on our open data warehouse website to actually put their data on there, because they're seeing the use and the benefits of people going and accessing that. We also have a form that goes alongside our report every week, which gives us positive and negative feedback from users every week. So we are getting feedback every week, and we are trying to take that feedback and build on it as we go forward, as we are quite a small team, quite similar to what Jennifer was saying. Not growing in size yet, hopefully we will. We've not had a chance to do that user research. So we're really depending on this user feedback every week to see, well, what do we need to make clearer? Because there could be information out there that people want and can see if we just direct them appropriately. So that's a couple of examples of the feedback that we have been quoted. So plenty of different spellings of statistics in those feedbacks. And one of our favourites is a bloody awful website. We try and take the constructive criticism and build on it, but we really need that to be insightful. So if we go on to the next slide. We've also, as well as our public-facing information, one of our teams has produced that contact tracing cluster analysis. So this enables our users to view index cases and contacts on a map at postcode level. So it's a bit more detailed than the public-facing dashboard that Emma was chatting about. And this is to try and show the spread of the virus. And the dashboard shows those spider diagrams that you can see there to try and view the connections of where the spread is happening, but does not infer direct transmission, because we do not know that based on the data that we have. So this dashboard has been designed to be intended to use in real time and to support the response to the pandemic as we are moving forward. And that's me. I don't know if I pass back to Scott. Go to the next slide.
Thanks very much, Jane. So just finally to say from me that as part of the slide deck there, we've got links to all the main sources that we've been talking about, so people can go and browse. And as Jade says, we really welcome feedback. So anything that you're thinking could be improved or added, or things you like, it'd be really, really helpful to hear that. So that's us from Scotland. Thank you.
Thanks very much. So now we move on to situation in Wales. So Alexandra from the Welsh Government will tell us about that. Alexandra.
Hello. So as mentioned earlier, I was supposed to be doing this presentation with my colleague Sean, but unfortunately he's not able to attend, so it'll just be me. So I'm Alex, and I work in the Knowledge and Analytical Services Department within Welsh Government. My team are responsible for the publication and the analysis of COVID-19 health-related statistics. We're a really, really small team and cover a wide range of topics such as NHS activity and capacity, personal protective equipment, care homes outbreaks and deaths, and of course, testing and contact tracing. And all of these topics have corresponding weekly publications, which are available on our stats and research on the Welsh Government website. In Welsh Government, we publish our testing and contact tracing figures in separate publications. So I'm going to concentrate more on the contact tracing side of TTP for this presentation. Could I have the next slide, please? Thank you. So I thought I'd begin with just giving a general overview of how TTP works in Wales. As Scott mentioned earlier, health is a devolved matter, and so our response and programmes differ to those in other countries. Our contact tracing system in Wales is all based around local contact tracing teams, which sit within our local health boards and contact individuals to identify their contacts, their exposure locations, and a wide range of other information to aid the contact tracing process. They also contact individuals to explain when they've been identified as a close contact, and they will advise them to self-isolate and provide the advice and support which is available to them where required. The benefit of having trained local contact tracers in our programme is that there's closer communication with individuals. And so I think there was a comment in the chat earlier, but that identification of cohorts or clusters is easier in some scenarios because they're a bit sort of more close to the information that's coming through. We do also have an e-form in Wales, which collects required information, but as the information that we obtain from the phone calls tends to be of better quality, the e-form is only currently used in certain scenarios where the contact tracers are unable to cope with the volume of cases feeding into the system. So over Christmas, that e-form was used to gather information on contacts because the system was sort of overwhelmed with the number of cases that we had feeding in Wales. Could I have the next slide, please? Thank you. So I've just got another diagram here, really, which outlines how an index case or a positive case sort of flows through our digital system. And the clocks here indicate where we're currently measuring this information, some of which we include within our weekly contact tracing publication. I've also included over here sort of examples of when a case would be deemed ineligible for contact tracing. So the majority of these are in hospitals or care homes, as these are closed settings. And the internal contact tracing processes and procedures are in place. I've also put in a bit of information here. So as we're using admin data for our analysis, as I'm sure we all are, there's always the usual issues that arise when using such data. So you can see here that a few records that started feeding through the system as eligible for follow-up then remained in a successful follow-up not recorded. So some of these are where contact was attempted, but tracers are unable to speak to an individual. But on closer inspection of the notes provided alongside these, we can also see that some of them have been incorrectly marked or coded, or that others are occurring in closed settings, so will later be marked as ineligible, which is always a bit sort of additional fun of processing this data on a short time scale. Could I have the next slide, please? Thank you. So as I mentioned previously, we publish a weekly statistical release, which is published at 9:30 every Thursday. It covers a number of performance measures around our contact tracing system, including the number of positive cases and the number of close contacts, which are both eligible and not eligible for follow-up by our local contact tracing teams. It includes the percentage of those that were successfully contacted, and it also includes the number of timeliness measures for those that are eligible for follow-up. I'm not going to give the detail for the process of publication, but I can certainly echo all the challenges that Jenny and colleagues in Scotland have outlined previously. And I'm going down a different route to my other colleagues here. For the next part of my presentation, I'm more going to cover a specific piece of analysis that my team carried out using the TTP data. So in preparation for the firebreak in Wales in autumn, colleagues internally were interested in the effects of previous lockdowns and restrictions, and looked at the number of measures such as testing episode, positivity rate, cases and incidents, contacts, and admissions and hospitalizations. So obviously none of these measures can be looked at in isolation when making any decisions, but I just wanted to cover in more detail what we looked at as part of our analysis on close contacts. So I have the next slide, please. Thank you. So intuitively, you would assume that the number of contacts a positive case generates will decrease during lockdowns or when restrictions are in place, but obviously, we wanted to see whether the data reflected this assumption. And to look at how the close contacts differed across the population, we decided that an average number of contacts per positive case was the most appropriate measure. We identified school contacts from our data by using the exposure location that's provided to contact tracers and removed these from our analysis because due to the nature of school bubbles and these resulting in far more contacts than would generally be created in the community, we just didn't deem this appropriate, and it would, result in misleading figures. So once we had the information sort of prepared and then analysed, we are able to plot this alongside when local and national restrictions had come into place. So could I have the next slide, please? Thank you. So we can see from this slide that from the Caerphilly local lockdown coming into effect, the average number of contacts per positive case in Wales started to decrease. And once further lockdowns came into place and came into effect, you can see that this downward trend continued. So obviously this does suggest that local and national restrictions do make a difference to people's behaviours and the average number of contacts that a positive case does generate. We've plotted a few different things on here. So through Wales, we obviously had a number of different local lockdowns happening over the autumn. And then we had our national fire break before then, our T4 coming in just before Christmas. And this red line here just indicates where the UK-wide Christmas restrictions were lifted for the time over there. As I've mentioned previously, obviously no measures can be taken in isolation, but this is one that is taken into account, and it was really interesting to see that the lockdowns do seem to reduce the average number of contacts that a case is generating. So I have the next slide, please. So as it was the first local lockdown that came into effect in Wales, I thought we'd just quickly look at Caerphilly in a bit more detail. As you can see here, the cases in Caerphilly were rising rapidly, and the decision to impose a local lockdown was made. So this meant that people were not allowed to enter or leave the Caerphilly local authority area without a reasonable excuse. Everyone over 11 was required to wear face coverings, and people were only able to meet outdoors. A lot of this, seems common practice now, but back then this was quite a big step, sort of moving towards what seems the norm for everyone these days. We could just move to the next slide, please. So here we've just plotted the previous chart for Caerphilly local authority. I just quickly like to note that the contacts at this level are volatile, so it's better to look at the overall trend rather than individual data points. But as you can see, the average number of contacts did decrease through the local lockdown, and this continued also through the national fire break, which reflects what we saw at the national level. Nothing that we're showing, I think, is surprising, but it is reassuring to see that sort of people's behaviours are reflected in the data and in the local lockdowns and national restrictions coming into place. You could just click to the next slide, please. I've done a very quick overview of the information and the analysis that my team carried out. I'd be happy to answer any questions that you may have on this. And I thought just quickly to mention that as well as Welsh Government's weekly publications on the topics that I mentioned at the start of my presentation, Public Health Wales also produces a daily surveillance dashboard, which includes a wide range of other measures. So if I hadn't mentioned something that you thought it should be being published for Wales, it probably is. It's just split between Welsh Gov and Public Health Wales. Thank you very much.
Thanks very much, Alexandra. So we now move on to the final speaker, which is Russell Black from ONS, talking about giving an overview of the infection survey. Russell, over to you.
Hello, everyone. I'm from the ONS, talking about the COVID infection survey, which is being run out of the ONS. Just to quickly run through what that is. So the aim is to have a surveillance survey that covers the whole of the UK and is representative by given characteristics. We will do repeated at-home visits operated by field workers who will manage the self-swabbing, or in about 10% of cases, the field worker is a trained phlebotomist who could also take a blood draw. And then there is a brief questionnaire following each visit that the field worker supervises. When it was set up at the end of April, it was a pilot involving about 25,000 people across 11,000 households in England, with the intention of ramping up to a full study that would be 150,000 visits per fortnight. As of last week, I checked the numbers, and to date we have done 2.4 million swab tests and 115,000 blood draws across 400,000 participants in 200,000 households, which I think comfortably makes us the largest social survey run in the UK that's not the census. This is very much not just the Office for National Statistics. This is a wide number of organisations that are contributing to this in some way, including IQVIA, our partner and including our collaborators at different universities. We are running all of the testing through the National Lighthouse Laboratories as well. At the moment, the Milton Keynes National Biocentre and the University of Glasgow Lighthouse Labs as well. So quite a large number of organisations have been brought into this project very quickly to stand the survey up to this scale. You may have seen some of the results in the news. I've got a few of the latest graphs here if you'd like to see them. One of the things we've been looking at particularly is the new variant, because it just so happens the new variant can be identified with the single gene target failure dropouts reasonably successfly. So we've had fairly consistent coverage of that since the new variant cropped up, which we've been publishing that. The latest data from last week is that it's about 1 in 55 people who have test positive for the disease in England. And you can see the new variant profiles there. I'll show you the other graph as well. Sorry, the y-axes here are different for the two graphs. We put out, in addition to the regular weekly graphs like that, quite a lot of other analysis based on the survey results we collect. So in particular, we focus on things like the occupation of the participants. So we're able to break down infection rates by whether the person is in a job that is patient-facing, is our overall definition. So it includes hospital workers, includes care home workers. We still, as the footnote says, would like to be able to break down the confidence intervals a bit more, but certainly that's the comparison we've been able to produce this week. Symptoms as well. We collect symptoms self-reported within 7 days of the test, but they do allow us to investigate different symptoms as well, and to break down the tests to symptomatic and asymptomatic cases, which you can see there for the last 2 months. Finally, from the blood draws, here are the latest results by region. You have still got a wide variety across regions, and for the other countries, we started in England earlier than the other countries, so the graphs for the other countries show the samples where we had enough blood samples to produce evidence for. You can see how it varies. I've got the link at the end of the presentation to the overall ONS COVID Insights dashboard, which has all this and more as we regularly update it. Finally, this is a graph I've taken from one of the studies which has been produced as part of the survey, showing in particular how growth rates of the new variant have compared to the old variant, which was picked up based on the data from the survey up to Christmas. Actually, I ran through that very quickly. Let me know if you have any questions.
Great. Thanks very much, Russell. And thanks to all the speakers. There are quite a lot of questions coming in on the chat, I can see. So, and we are happy to take questions after as well. So what we want to move on to now is the Q&A session. this is Manira will be able to, is volunteered to summarize and highlight some of the questions, and I identify who they are aimed at. So Manira, if you can run through and summarize some of the questions, and then we'll go back to the speakers and give each one of them a few minutes to pick up on the ones they think are most relevant to them. So I know this is a bit of a challenge. There's an awful lot coming in, but anyway, so over to you.
Yeah, thank you very much, Dina. Thank you indeed. And thank you to all the speakers. That was really, really interesting. And I don't think anybody's made my job any easier because the chat has been on fire. So thank you for those that have access to chat, because I appreciate some of you may not, depending on how you've joined in today. But those that have put some really, really interesting questions. And then also a thank you to some of the speakers that went before others who've also been responding. So in a sense, it's made my job a little bit more difficult in kind of pulling this all together. But what I think, Dina, would be helpful, if it's okay with the speakers, there are some questions that are specifically aimed at individual speakers, and there's a few general ones. So if it's okay, I'm going to start off with them focusing on the speakers as they came in order. Jenny, I'm going to come to you first. There's a few questions. What I will say is that I don't think we have time to cover every single question, as Dina said. So the speakers will be given all the questions after the session, and we'll have a chance to kind of pull together a response if we're not able to cover it now, either through our chat or talking out loud. So we will get back to individuals. So thank you for those submitting questions, and please do continue to do so. So Jenny, if it's okay, if I can come to you firstly. So there's a few questions. If I maybe pick one or two, and then I'll give you a chance to kind of respond to some of that. I'm trying to think what would be the best ones to do, but I'll just go through in the orders they were coming in. So we had a very first question from William Palmer. So thank you, William. And he was wondering what type of governance was used around the choice of methods that you refer to, and the scrutiny as well, because he was referring to some of his own stuff around the gaming of statistics, but he was wondering around the governance. And the other question as well, we had one from Professor Nick Payne. He was talking about a study that was in Sheffield, Jenny, that shown that the NHS test and trace programme was poor at picking up inpatients with COVID diagnosis. And was there any plans to address this? So over to you, Jenny, for that. Thank you.
Great, thank you. So I'll just kind of address both of them. And for the first question, so in terms of our methods and how we decide how to report things, generally we're reporting on the operation. So we will report exactly how the programme records data or their process of contact tracing. And we don't have a lot of, I guess, influence over how they decide to do things. We do work very closely with operations, and we work closely with our head of profession for statistics as well. So there is a sort of two-way conversation where, we can feedback to them if we're not sure about the data being reported in the right way, and also we sort of clarify things with them as well. So this is kind of like two-way dialogue. I think the question you asked in particular about duplicate contacts, so that's something that came up quite recently. When we had a small number of contacts, that wasn't a big concern really, but now there's obviously a lot more people testing positive. You do get cases where someone is going to be a contact more than once. For example, if 2 people in their household test positive, which is why we've sort of tried to make that clear in our methodology, and we do try and be transparent about how we're doing everything. But in that case, the way the programme deals with duplicate contacts is they will contact them twice, so they just end up in our system twice. So we're sort of reporting on exactly the way the programme deals with them at the moment. There might be scope for us to do something else with that, maybe some kind of deduplication, but that would require another sort of project of work for us. So if that is something someone would be interested in, let us know, and we'll sort of consider it on our backlog of items. And then the second question was about a study, I think. I haven't seen the study, so I can't comment on that, but I do know everyone who tests positive should get transferred to contact tracing, but it might be if someone is quite sick in hospital that are going to be harder to contact trace. I don't know anything else about that in particular, but if you pass on the study, I can pick that up with people in operations. You're probably a better place to answer that one.
Great. Thank you very much, Jenny. And I appreciate some of these. Some of our speakers will not be able to answer, and we'll need to do a bit more digging. But I think that was a clear call just for Professor Nick to maybe share that study with you. So thank you very much, Jenny. That's great. I'm going to move on to Team Scotland, and hopefully you'll be okay me calling you Team Scotland. You've been really busy on the chat, so thank you very much, which has made actually the job very easier. So I'm only going to pick up maybe one or two questions, and Jade, Emma and Scott, feel free for any of you to answer that. And I know the chat's still going on there, Emma. I think I've just seen your kind of a recent post in there as well. But one or two questions, if you could take on board. So, and again, I'll summarise them both, or two or three together, and I'll just hand over to yourselves. So one of the questions, and this is from an unknown, was, are there any plans for NHS Test and Trace weekly report for local authority level data to be included? And that kind of links on to one from Kate Croft that's recently put in, and she's asking, can you say a bit more about the cluster analysis you have done? Is there a link to this that she can see?
Okay, so I think we like being called Team Scotland, but we're probably all looking at each other to wonder who's going to answer the questions first. I think to take that first one, I hope it was clear from the presentation that Emma gave that the data is available at local authority level in our daily dashboard, and we present both daily and 7-day figures, so you'll be able to get a big detailed breakdown by local authority there, and then within the local geographies within it. And then within our weekly publication, it tends to be a mixture of geographies depending on the statistics. But for example, the recent statistics we're publishing on vaccinations, we do go down to local authority level. So you can see all of that there. So probably I would suggest people have a look at both of those. And we're always welcome. It's always good to get the feedback around what's available. So that was the first one, Marina, and I've forgotten what the second one. I've been distracted because although we've got snow, I fed the birds this morning and my garden is now like a scene from that film with so many birds coming down to get the food.
The second one was around the geospatial tool and a bit more information on that. Yeah. I don't think our colleagues who developed the tool are here, but we can certainly set up a separate presentation on it because it's a really in-depth tool and there's a lot to cover. So we only gave you a bit of a flavour today to incite you in. And it's only available to NHS boards, and it's designed to be a management user tool to actually identify clusters and go in and make the response more effective and to see if there's certain hotspots. It can certainly provide more detail and arrange for the team who developed it to do a one-off presentation. So I hope that kind of answers your query.
Oh, super, Jade. That's really helpful. And I see somebody had asked about the GitHub as well, and you've posted the link in. So if the plan is to post some additional, not just the presentation, but additional links to any other pieces of information covered today. So maybe we can pick up with that offline and we can share that wider. Emma, is there anything else that I know you've been furiously responding as well to some of the chat? Is there anything, those that can't see the chat, that you may want to pick up and just share?
I think I've responded to most of it, but I'm happy to put my contact details there, the contact details for the daily dashboard team, if people want to come back with any further questions in that respect.
Great, super. Thank you very much. And now I'll end by saying thank you, Team Scotland. It's got a ring to it. So I'm going to move on to the next, Alexandra. Thank you very much. And I see you also have been kind of chipping away in the chat, but a few questions for those especially that can't see the chat as well and some of your responses to it. So I'll pick one or two questions. And again, thank you for everybody that has been putting the questions in. So I'll just pick a couple, if that's okay with you, Alexandra. One of the questions from Jacqueline Clay that came in is how are you defining an index case? First date of specimen within the household. And we have a question from Nigel as well, Nigel Applewhite, which is about how have you done any predictive modelling for the next 3 months and the impact of vaccinations in Wales and positive contacts? Over to you, Alexandra. Thank you very much.
So in regards to the first question, an index case is essentially a positive case. So I think it was in my slides, you sort of can see the flow chart. Essentially, if you have a test and you get a positive result, you feed directly into our contact tracing system. Now, if you're already in there for whatever reason, because you were already a contact, that will be picked up by the local contact tracers. And, the system sort of will be updated accordingly. But essentially, an index case is a positive case. So if you receive a positive test result, you will feed directly into our contact tracing system and be contacted by a local contact tracer. I have responded to Nigel. So my team specifically is sort of responsible for the publication of the figures. So we'd actually do any modelling within our team, but there is a technical advisory cell within Welsh Government that do a lot of modelling, and we work a lot with academics. So I've said to Nigel that I'll find some links to previously published models that I can include as part of the slide pack when we circulate. And he's also providing me his details. But I think for other kind of attendees, just to be aware of, like there is modelling ongoing at the moment. It's just sort of not at the point of publication quite yet. I think there's so many very important decisions based on these models that they take a bit of time to sort of finalise and approve before, to make sure that they really are telling the real story. I think obviously you can't really tell a story in the future, but predict it as best we can. So I'll provide my best links as I can. And I can always follow up with Nigel afterwards if there's sort of any newly published figures and newly published models.
Thank you very much, Alexandra. And it comes back to the very first point that this is such a changing world for all of us right now. So what we're talking about now could be very well out of date in a couple of months' time. So I think your points are taken well on board there. Thank you very much, Alexandra.
Thank you.
And moving on to Russell. Russell, I see you've been putting some comments in the chat, so thank you very much. So I'm actually going to ask you one of the questions that was asked to all of the speakers. And if I can get down to it, because I've got so many here in front of me right now. Where it is. Here we go. So it's by Roger Boyle, Russell. And he was asking, how does statistical provision in other countries compare to what we're doing and what we're using in our organisations, especially around Russell. So I was wondering if you could answer that. That'd be great.
So I can only speak for the surveillance testing, which is the element that we're involved in, and strikingly, the UK is doing fairly well in the consistency of the surveillance testing that we're doing. Because it's not just us. There is the Imperial Ipsos Mori React study, which is sending out waves of posted self-administered swab tests, whereas we're doing in-person visits. So by having the two different methodologies running in parallel, we're both complementing each other. On top of which, the Zoe app, who, if you follow them on Twitter, they often put out some very, very nice graphs comparing themselves, React and us. That does give you quite a wide range. Alas, in terms of comparisons internationally, the ordinary case rates has sort of defaulted as the most comparable across the most number of countries. So I can't quite, I would like to be able to answer you in a bit more detail than I can.
Thank you very much. And Russell, just putting you on the spot there, and I know there's a lot more behind that. And that's something, and thank you for your question for that, Roger, and that's something we will share with all the speakers to reflect and come back to you on. Dina, remind me, how much time do we have left now, as I hand over back to you?
We've got another sort of 20 minutes or so, so you can run through some general questions. Great. And then go back around the panel again. So just maybe 5 or 10 minutes, and then give the each of the speakers a chance to have another couple of minutes.
Sorry, there's a question from Robert Whitehead, which I didn't answer.
Yes. Please, Russell.
So I just all of my presentation was taken from the ONS website. If you go to the ONS website homepage, and then coronavirus latest insights, that takes you to everything that the ONS is doing, including us, and that has the latest data. Is anonymized single case level data available? When the study protocol was written up, that wasn't put in it. So if you are a accredited researcher, there are mechanisms for accredited researchers to access safely microdata, which I won't go into it here. Otherwise, we put out a large number of tables, and if there'll be more tables that would be useful, then we're very happy to receive feedback. I hope that answers most of your question.
I think just a point in general of what we did, we asked the speakers to say that that because this is going to be recorded and made publicly available effectively on the website, that they were presenting material that is publicly available, and any links to supporting information and links to the material will be in the meeting report. So, we've got an opportunity that you can follow up with links after the presentations.
Great. Thank you very much, Ursula, and thank you, Dina. I do have a few general questions, so I'm going to open this up to all the speakers and all the nations to come in. So, in no particular order, please feel free when you're ready to answer. But the first one I'm going to focus on is on ethnicity data, and we had a question there from your side about plans of using, updating, and publishing ethnicity data. And I was wondering if there's any updates the nations would like to share on that, on their progress.
Yeah, I can give a quick update. We do want to publish ethnicity data. We did actually publish some back in September, but then there were issues with the data quality, so we haven't published it for a while, but we are still trying to get that back and published as part of our sort of testing metrics. So hopefully we'll have something on that soon.
Great. Thank you very much for that, sharing, Jenny. Team Scotland, coming to you. If there's any updates to share.
I think Jenny made this point earlier, but the biggest challenge that we find is the data going in really does affect the data that we're able to report back on, and the recording of ethnicity really is quite challenging. And the data that we've got coming in, it just really isn't reflective of the data. So if you were to release the information that you have, then it could be quite misleading. So we've got quite a lot of ongoing projects to try and link the data together to try and see if you can find where ethnicity was potentially recorded, to try and filter it through to other systems to then apply some sort of ethnicity analysis. But it is on our radar and is something that we have published, and we will publish again once we find more time to have more in-depth and accurate data, I think, is the big thing, or reflective data of what is happening.
Good. Thank you very much for that. Jade, can I come to Alexandra from your perspective from Wales?
Yeah, I would echo, that's not a word, sorry, echo my colleagues' sort of comments on this already. I mean, it's on our radar. It always is on our radar. Every statistical publication that we do, we try to include some sort of ethnicity breakdown. The difficulty being the data quality and the sample sizes that we are, we want to include that breakdown, but we want to be confident that that data that we're putting out there is of robust nature and of a certain level of data quality, which at the moment we can't guarantee. So I guess it's the same as everyone else. We want to do it. I can't say that we have done it already, though, so everyone's beating me to that one at least. But it's definitely something that we are looking into and hoping to be able to do in the future.
Great. And Alexandra, just that, you were looking into, is there plans to work across the nations on this as well? Is this an opportunity while all the different nations are on, that we can work together and kind of learn and share as we develop a process? Or is that already happening?
It's already happening. I was going to say, it's normally my colleague Sean that attends those meetings, but we do have a fortnightly catch up with each other to sort of share what's going on and what we're doing within our different nations. So
great, and that's part of it. Great, Alexandra. Thank you very much for those that weren't aware. So it's really helpful for you to share that. Russell, I'm not sure if you'd like to add anything additional from your perspective into this as well.
No, other than we also work closely with all of the governments when we're publishing requirements and working through the survey.
Great, thank you, Russell. I thought this would be the most challenging part of trying to get people's questions answered, but between the chat that yourselves have updated, we've actually managed to go through quite a lot of the questions that have been raised. So firstly, a big thank you for everybody that has been raising the questions, that's been able to do that through chat, and also to our speakers for not just verbally giving us updates, but also jumping on and sharing some links and sharing some more updates in the chat. I'm also conscious, we know, Dina, we've got this on for another 15 odd minutes, but it'd be nice to give people maybe 5-6 minutes back of their day to either stretch your legs, make a cup of coffee, or what I like to do, a quick 2-minute run on my recently purchased treadmill. So I'm going to hand back to you, Dina, just to give us a bit of a summarise and next steps. Thank you, Dina.
Okay, well, yeah, thank you, Munira. That's always, like even more challenging the presentations, I always think, running through and trying to sort of summarize. And thank you very much for the speakers to sort of, being put you on the spot there. But just really, confirming, reiterating what we said at the beginning, in that the presentations will go up almost immediately because those are all ready and available. And we will then be putting up the recording of this, but in order to give the speakers a bit more time to come back, we will be documenting all the questions and the answers. So there will be some further responses with links and any other information, which we will then post. That will be posted on the Royal Statistical Society website, and also on the Health Stats user group one. We'll send information about how to get access to that round to everybody. If you have any other questions that you have, you're now thinking about, then you can still send them through. You have the kind of webinar address that will remain active if you've got any further thoughts. So one other thing that we, the speakers, were quite concerned about was that things, as Munira said, things are changing quite rapidly. And so this is the situation as at today, but obviously there may be new challenges, new things developing. So some of the speakers had suggested that maybe we would rerun this in maybe 2 months, six weeks time or something. So we will be actively looking at that to see if we can revisit this webinar with some more updates on the methodology and the way things have gone. So we'll come back to people and let people know about that, because I think that would be very interesting. So I don't know if any of the speakers want to have any final thoughts, but I think following Munira's suggestion, that it's we've got a lot of content there people want to look at. We don't necessarily want to run on and take up more time if we've actually got to the end of the Q&A. So I would suggest that we now say thank you very, very much to everybody, the participants, and also to all the speakers, and Munira for pulling together the Q&A at the end. And we look forward to further exchange with you. Feel free to keep offering comments and thoughts, and also any other suggestions about other webinar topics within the COVID-19 statistics theme, which is what we're running. So please feel free to email us on that webinar address and let us know. So unless anybody else on the team wants to jump in with any final thoughts, I think I'll close the webinar now, but look forward to further exchanges by email and on the website. So thank you very much, and have a good rest of the day.
Thank you for organising. Bye.
Bye.